you as a co-host, so hopefully you'll be able to, but
okay.
fingers crossed.
Has
Lovely.
that come up? Can you
I
see
can see
that?
that,
I'm
yeah.
going to, sorry, just try and take it to, is that big enough on your screen? I can't really see now how big it is.
It's okay on mine, but I'm on an actual screen, so.
Okay, I'll try and make it a bit bigger.
That's better, Caroline, thank you.
I can't get it to do the from the beginning thing, you know, with the slideshow. So I'll just have to go with that if that's okay.
Absolutely.
Yeah. Okay, so good evening, everyone. Yep, I've introduced myself just before, and I'm going to try and move us on to the next slide because I've got a bit of a long-winded title there. So if I explain what that means, I've got, it's described as almost two hats. I've got two roles really. My actual job is I'm the Associate Director for Operations with Pennine Care. So I'm generally responsible for the secondary care element of mental health provision in Rochdale. So overseeing a lot of the activity on the Birch Hill site and some of the community mental health teams. But my wider system role is within the One Rochdale health and care arena, and I'm senior responsible officer for the whole system mental health approach. So some of what I'll talk to you, the majority of what I'll talk to you this evening is about the system approach to mental health. A lot of that does obviously include Pennine Care's remit within that, but it's also a much wider agenda. So some of you will be more familiar with the concept of a local care organisation, the LCO, and ours here in Rochdale is described as the One Rochdale Health and Care Organisation. It's been, I would say, around for the last 3 years in that terminology. Prior to that, it was working as an LCO. And I've been in the borough for about 4 years now, and we've really seen an awful lot of developments. And the priority areas are listed there as work plans associated with mandates, but the 6 areas that we're focusing on as an LCO, which is our providers and commissioners and wider stakeholders, our voluntary sector, the whole system really, anyone you could think of in adult care who's trying to work together to provide health and social care. This is our new governance framework that helps support that. So as I've listed there, we've got the priority areas of urgent and emergency care, planned care, neighbourhoods, mental health, children and primary care. So we're going to talk to you tonight about mental health, and it is primarily around adult mental health. There's a lot of work going on around transitions and that group, probably between sort of 16 to 18 and then up into 25 is an area that is emerging as a cohort that we want to look at, but we are going to focus probably from 18 upwards. Okay, so as I've alluded to a little bit before, back in 2018, the LCO within Rochdale wanted to really put mental health on an equal footing with physical health. When the groups of people leading all the various parts of the system in Rochdale came together, there's been a real recognition, and this isn't just in Rochdale, but it's nationally, and we've seen a lot more recently that people recognise that mental health hasn't always had the platform or the investment or the attention or anything really to actually place it in as stronger position as physical health. So there's been stigma associated with mental health issues, and in a very welcome way back in 2018, the leaders in the Rochdale system really wanted to put that at the forefront of the work that we were doing. So it feels a long time ago now, but actually it's only a few years ago. We did hold a wide event, which best part of 200 people attended, to actually bring together all the views of what people wanted from mental health services, to describe what they actually felt the current system looked like and what we could do to actually try to resolve how we work better together. Sorry, just let me move on. So I think you can see there's two kind of bubbles really there. Some of the words on the top left describe how people felt the system currently was. So this word cloud of what people's experience was this captures a lot of the common themes really there. So around a disjointed system, services being fragmented, uncoordinated, hard to reach. And I think over the course of that particular day and the work that we've done since, there is a very much emerging picture of something that's a lot more hopeful and optimistic. The words at the end there, sorry, on the right-hand side, describe primarily kind of how people came out of the room that day, feeling that we've got an energy behind this now and there's a real priority as a system to work on this. So when I've described mental health not having the esteem that it needs to, I think in this particular borough, we've been working on that for quite some time now. It isn't the recent shift in, I suppose, media attention and government attention that's prompted this. We've been on that journey for some time. So bear with me. So on the back of the momentum there that was gained with the One Rochdale support, we began to work together as a group of stakeholders, and colleagues like Leslie and our Mind colleagues who you're going to hear from after me, we've been working on this together for a number of years. And then I would say probably more over the last year through the COVID experience, as much as it's been a challenge, we've actually come together in a wider group a lot more effectively. We've got better engagement now, like with Tracy and colleagues from Healthwatch. We've got our voluntary and wider third sector partners much more on board with a lot of the discussions. Our clinical leads in the borough are much better involved. We are working towards a better co-production agenda, and we've got a living well model that's emerging, which I'll talk a little bit more about. So we've kind of had a governance structure around that for the last couple of years that has been around a partnership board. I co-chair that with one of our lead mental health commissioners, which in itself reflects where we've come to as a system. So there's a lot more, I would say, collaborative work with us to ensure that commissioners and providers are using each other's expertise. We work jointly on projects. We're not as separate in our agendas, and I think that's actually bearing fruit now as to how we actually look at our outcomes for people in the borough. I've referenced there the neighbourhoods, and there's a lot, some of you, I think a lot of you have got professional backgrounds, be aware of the integrated neighbourhood teams and how obviously the physical health agenda and people accessing help locally via the INTs has been something that's progressed an awful lot in the last few years. Our mental health alignment to those teams is improving. We haven't had the resource at a formal level to actually work as closely with the INTs, but that is one of our key work streams. And then just below that there, we've got our primary care networks. So we've got in Rochdale or across HMR 6 primary care networks. And the emerging discussions at the moment are around having dedicated mental health professionals who will serve each of those 6 primary care networks. We need to do a bit of work as to how the primary care networks and the integrated neighbourhood teams will function together, but that's not just for us in mental health to do that. We're working that through for all of those arenas. We're working closely with our colleagues around inequalities in the borough, and that's around social inequalities, but also around our BAME cohort and how we actually reach our diverse communities and understanding need better, particularly in relation to mental health, because that can have nuances dependent on various ethnicity, various cultural backgrounds. And this is a piece of work that we've had some support to understand better. But again, this is one of our key work streams going forward. I've referenced there the co-production agenda and the living well officer. Oh, jumped ahead there. Co-production, I suppose, just to understand what co-production is, it's around actual expert experience. So we're very good sometimes as professionals about kind of counting how many admissions we've had to hospital or how many attendances we've had at A&E, but we really need to get better at understanding people's experience and people's stories as to what actually makes their life feel better. So day to day, what is it about personal experience, whether you're a parent or somebody who's got homelessness issues, drug and alcohol issues, all those kind of things that challenge each and every one of us on a day-to-day basis, and how we can actually know what we need to target our approach to support and how we know when we've done something well or where we need to improve it. So looking at how we actually tell our story better and actually listen to people to influence our strategy in the borough as well. I On this next one, the Living Well offer, and this is something that it's not at all unique to Rochdale. It's not even unique in a Greater Manchester perspective. It's an offer that is established right across from a national perspective, but it looks at how we seek to deliver help. So the getting help agenda is something that is common right across physical and mental health settings. And it's just to make sure that people get the right kind of help and that they get help as close to their home as possible and they get it as quick as possible. It's to avoid people having to really deteriorate and need to come to A&E to get help when actually they could have had something early doors by somebody who understands the local networks and can tap into that local support. And if you do get your local support, you're more likely to engage in it and engage with it for a longer term as well. I suppose emergency support is something we're trying to move away from. It's more about informal local support, and when people do need that high-end emergency support, that it is there for them appropriately. I'm whizzing through here and I can't see anyone, so tell me if I'm rattling on here. There's an awful lot probably to take in this next slide. I'm conscious it might even be a bit blurry, so I'm happy to share the slides afterwards. But what we're trying to capture within this slide is the key priorities for this next year. And some of these have already been in place prior to this year, and they will continue beyond the next year. But as part of our mandate work, as we've described it within the borough, we're chunking our work up into 3 significant work streams. At the top there, we've got alignment of community mental health teams and third sector services into the INTs. So this is around what I described just before about ensuring that our service users who do come into contact with secondary care services have got pathways to get into service and out of service rapidly and back into that care that's delivered locally with the primary care networks and with the integrated neighbourhood team. We're looking at person-centred approaches and to actually improve the support we provide to our GPs to ensure that often GPs that, as you'll all know, GPs aren't, they're very good at what they do, but they have to encounter an awful lot of different conditions. So actually supporting GPs to better understand mental health need and for us to work closely with them to ensure that they are able to better signpost and get the help that people actually need. So we've got a big kind of education programme that we're doing jointly as a system. Then we've got our crisis management and urgent mental health offer. So there is investment from a GM perspective into the crisis offer. Some of that has been, it's happened quicker than maybe it would have done because we've had a real impetus to get helplines set up through COVID. And we've also had a need to support people better because when people weren't able to attend A&E or were discouraged from attending A&E, we had to set in place different mechanisms to support people, whether that was by video triage or telephone contacts. So some of the things that have happened over the course of COVID have, it's been a challenge, but actually we've learned things and we've put into place systems that maybe would have taken an awful lot longer to actually occur. But alongside that, we've got investment to actually better support our crisis offer. So working closely with our third sector, and I think Mind may come on to describe some of the work in relation to that about our crisis support around crisis cafes and how we actually support people out of hours and in less traditional settings. And then we've also got our dementia strategy. Now, this is something that was already well underway pre-COVID. I think we've had less capacity to deliver it as was described before COVID. But nationally, it's been recognised as one of the better pathways for dementia within the borough. And this is very much delivered right across the system. So we are, again, educating our referrers, going into care homes, looking at how our GPs work with people and aiming to ensure diagnosis happens as rapidly as it needs to, and then getting that after diagnosis support. So that's an awful lot of work described in something very rapidly there. So, and then just lastly, I thought I'd just touch on some of our Pennine care developments. As I've referred to, we did establish a 24/7 helpline. I think it was back in April last year as in a response to COVID, because I think it was just to ensure that people did get the mental health support that they needed. We've introduced the emergency care by appointment scheme, which is in response to supporting A&E. Up on our site here at the Birch Hill Hospital, we have for years had dormitory accommodation for our patients. And for any of you who have had to visit the John Elliott unit or have been here as a patient or a carer yourself, you will understand that the dormitories sound big, but actually they're really, really small. And we've had, up until very recently, four bed dormitories, which just weren't fit for purpose. They weren't where you'd want to be cared for, particularly at a time, if you think about people on our wards, often they're detained under the Mental Health Act at a point when they're very vulnerable. So one of the things I think I'm personally most proud of is that we've actually managed over the course of the last year, and actually mid-COVID, been able to eradicate the dormitories. We've now got single bay accommodation for all our patients, which I think going forward is a massive shift to people's experience on our wards. We have moved to single gender as well. So we had mixed wards previously, but now we've got male and female wards separately. And within that, we've developed the therapy hub, and we're also, Lucy's on the call. I noticed she's down at Lawrence House. We've got our mugger down there, which is our multi-use games area. So we've got an outdoor space that's safe for our patients to be able to actually come off the ward and enjoy some kind of football or basketball activities, whatever we choose to use that for. And then a big piece of news there at the end that has been a long time coming is investment into our community mental health teams and into our crisis teams that we'll see emerge over the course of this year that will really help support those who need that high-end support at a point of crisis. So I've put on here any questions, but I think I'm going to come back for questions when you've heard from the other two speakers. Don't know how I did for time there, so if I've rattled through, forgive me, but I'm going to hand you over, I think, to Leslie.
That was lovely. Thank you very much for that.
Thank you.
Okay. Can everybody see Leslie's slides?
Yeah.
Yeah, fantastic. Yeah. If you just let me know, Leslie, as you want me to move on, I'll do that for you.
All right, okay, thank you. So my name's Leslie Stutter. I'm the service manager of Thinking Ahead. I've got a presentation here. I'm not going to read it verbatim. I'm just going to sort of summarise each slide really. So just to start off with who we are, Thinking Ahead, it's a partnership, a mental health wellbeing pathway in Haywood, Middleton and Rochdale, and it's made up of 3 organisations: the Big Life Group, we're the prime provider, and we subcontract Pennine Care and Gadam to provide the service, and we're commissioned by the CCG. And what we do is we offer a range of clinical and non-clinical interventions to people experiencing common mental health problems and challenging life circumstances that could be such as housing issues, finances, social isolation. Can you move on to the next slide? Thank you. So a lot of you might have heard of IAPT, but actually not realise what it is. So IAPT, it stands for Improving Access to Psychological Therapies. And it's a national programme that was established in 2008 to basically enable more people with common mental health problems to be able to access evidence-based psychological therapies. And all the therapies that we offer are follow NICE guidelines and are recommended by the National Institute for Health and Care Excellence. And we offer what we call a step care system as well. So basically the step care system, I won't go into it in detail, is that we offer somebody at first the least intrusive intervention that we can. And if that doesn't help, if they don't recover, we can offer something else. And people should seamlessly move through our pathway until they do have a positive outcome. That's the theory. Next slide. Thank you. So this diagram here sort of explains the way, if you like, on a page, the organisation works. So the little people at the top, they're the client, the service user. So you can refer yourself to Thinking Ahead. We accept self-referrals. In fact, 70% of our referrals are self-referrals, and you can do that. People can do that by just ringing up and speaking to one of our admin team, and we'll take a referral over the phone. Or you can Google Thinking Ahead and go onto our online portal and fill in a referral. Or likewise, a GP can make a referral for you, or it can be made at one of the community hubs, one of the neighbourhood teams, or any other sort of professional can make that. We then triage all our referrals that come in within 24 hours, and then people are offered an assessment for either therapy, or if the referral indicates that that person might have more complexity or may not be therapy ready at the moment, they'll have what we call a gateway assistant with one of our mental health practitioners. So following the assessment, people are then offered the appropriate therapy, which might be one of our evidence-based therapies, or it might be from our Getting Help team, which Gadam run, and I'll explain that a little bit more in a minute. And that's our non-therapy offer around providing social support. And then following therapy, we might signpost somebody to one of our community groups. We work very closely with Living Well, who we might then move on to a coach, a live coach, or it might be some online support. Think of the next slide. We offer a number of different therapy choices, the way that we deliver our therapy. So one of the therapies that we offer is e-therapy. So that's an online therapy using what we call Silver Cloud. So people can log on to a therapy and be supported by one of our therapists. We do telephone therapy, one-to-one telephone therapy, or over a video platform. We offer face-to-face therapy. That is limited at the moment due to COVID, and we do have to follow all the sort of the PPE guidance and social distancing. So that is quite a limited offer at the moment. But as we come out of COVID, we'll be working towards going back to our usual face-to-face offer. And then we offer a number of therapies, groups and therapy workshops. And at the moment, those are over video platforms, over Zoom. But when we come out of COVID, we'll be doing our normal groups, our face-to-face groups. And then we offer a number of online stress taster workshops where people can get a taster of the service, if you like. And we've just launched those. I'll talk about those a little bit more in a moment. And our venues are, well, we're not in COVID throughout HMR. At the moment, we're just limited to seeing people in Rochdale, at the Rochdale Infirmary site and at Lock 50. But when we are coming out of COVID, we are usually in a number of different GP surgeries and community centres. So going forward, we'll be back in those venues again. So just to explain what the different partners do within the service. So our Getting Help offer, that's a small team of support workers who provide what we call our non-therapy offer at step one. That's our sort of lower offer. And they support individuals whose low mood and anxiety depression is maybe being primarily caused by issues such as finances. It could be around being socially isolated, housing issues, addiction, drugs or alcohol. And they link in with 5 partner organisations in Rochdale. So that's Petrus, Rochdale Connections Trust, Rochdale Women's Welfare Association, the Recovery Republic and the Proud Trust. So they have SLA agreements to work with those partners. So they work very closely with those. Next slide, please. So the Getting Help team will see people on an individual basis, or at the moment it's over the telephone, and they'll see them for up to 4 sessions and put support plans in place around whatever their presenting problem is that they want to work with. And they'll also signpost people to various other services around whatever the issue is they're working with. And like I say, they work very closely with the 5 partners that they have. And usually when not in COVID, they are based throughout HMR, and they do drop-ins in different community venues. So you can, just go up and have what we call an initial conversation with one of them around whatever the issue might be. So then one of our therapy offers is CBT, and we do that at low intensity and high intensity. So our step 2 practitioners are called psychological wellbeing practitioners, or PWPs as we call them, and they're trained to work with people who might be experiencing anxiety, depression, panic, OCD and common anxiety disorders, and they deliver what we call guided self-help, CBT, and it could be things around sleep hygiene, problem solving, relaxation, behavioural activation, doing behavioural experiments and cognitive restructuring. And everybody that comes into our service of therapy, we ask them to complete 2 specific questionnaires. One's to measure somebody's depression and the other's to measure somebody's anxiety. And these are evidence-based tools that we use, and the clinician goes through these at each session, and it enables the person to see their therapy journey, whether they're making progress, they're getting better or they're not, and we can actually then plot somebody's recovery at the end of therapy. And the next slide, please. We also offer counselling. We have a team of counsellors, and we say we offer 6 sessions as a standard, but that's negotiable dependent on each patient's, each client's journey. And the way the counsellors work, it's around people who want to reflect on past events. It might be around bereavement, relationships. And we also offer specifically counselling for depression. So that's somebody that may have a depression for more than 2 years that's been treatment resistant. So we will offer counselling for that. And we also offer couples counselling as well. Have the next slide. Thank you. And then we come to the part of the pathway that Pennine Care deliver, and there are high intensity CBT therapists. So if somebody's not had recovered at step 2 at low intensity, we might step them up then to high intensity CBT. And this is quite a protocol driven treatment. There's a different clinical protocol for each problem that you might see somebody for. So they work with people with anxiety, depression, panic, OCD, PTSD, trauma, and also for a single episode trauma, we offer EMDR, which is eye movement desensitization reprogramming. That's quite a specific therapy for somebody that's got a single episode of trauma. And within that part of the pathway, we also offer an 8-week mindfulness course, and we offer an emotional skills group. That's a 20-week course for people to support them who have difficulties regulating their emotions. And again, everybody that enters in that therapy completes those 2 clinical measures to map the progress as well. And the next slide, please. We also, Pennine Care also provide our psychology part of the pathway. So the psychology part is for people who have quite complex presentations, and they may have had multiple difficulties that have occurred over a number of years that result in quite a complex presentation, really. So it could be things like a history of trauma, abuse, and really quite significant mood problems. They may have had a number of episodes of therapy, of CBT or counselling, and not really had a positive, sustainable outcome. And it's for people who, although there's complexity there, it's a lengthier therapy. So it could be 20, 24 sessions that somebody has. So people have still got to be able to engage and commit to weekly therapy appointments and actually be able to recognise and come up with a therapy goal that they want to work with as well. And the next slide. And then the other part, the last part of the team that we have what we call our gateway team. And that's made up of a small team of mental health nurses and mental health social workers. And the gateway team triage all the referrals that come into the service. And we get a number of referrals that the people there might be quite a complex presentation. There might be issues around risk taking, safeguarding, and complexity. And there might be people that come through that are not therapy ready yet for those reasons. So they offer a more detailed mental health assessment, and there might be some stabilisation work that we offer before therapy would be appropriate. Or it might be that that person isn't appropriate for our service and we need to get them to the right place for them. They also would see somebody, if there's maybe some psychosis present that's come through on the referral, or around medication management. And the Gateway team work quite closely with the Enhanced Access team at Pennine Care around if somebody, maybe is too complex for our service and we need to get them to Pennine Care, to secondary care services. The next slide, please. So as I touched on before, referral to Thinking Ahead is really, really quite simple. We welcome self-referral, so you don't have to go through your GP. You can literally ring us up. If you see us when we are able to be out in the community at any events that we're at, you can just come up and we will accept a self-referral. Again, you can Google Thinking Ahead, just fill in our online portal. And any of the workshops that you attend, you can make a referral there into the service. And for professionals as well, we have a professional portal where we accept referrals from professionals. So again, as I touched on before, all our referrals come in to the service. We triage them within 24 hours. They receive an assessment within 2 to 4 weeks. You'll have an assessment, and then you will go on to whichever therapy list is appropriate. It's a collaborative decision that the person makes with the clinician that's done the assessment about which therapy pathway that they go on to. Everybody that's had an assessment, each case is discussed in what we call case consultation with a senior member of the team to ensure that that therapy pathway is the right one for that person to be on. Okay, next slide. So the one thing about IAP services is we're very transparent. You can see how well we're doing, or you can see how not well we're doing. So our data is collated on a monthly basis and it's produced nationally. And we also have some national targets that we have to meet. So we have to ensure that a certain number of new people come through our service, our prevalence target every month. We have to demonstrate that that 50% of the people that come through the service recover. Obviously, we want more than 50% of people to recover, but that's our target. And that target is measured by those 2 questionnaires that I spoke about, the anxiety one, the PHQ-9, and they're called the GAD-7. So they record if their scores indicate whether somebody's recovered from therapy or not. And then we have some waiting time targets. So 75% of the people that must access the service within 6 weeks and 95% within 18 weeks. And then a completion of therapy target as well is 75% of people who've accessed the service within 6 weeks, and again an 18-week target. So that's a retrospective target that measures all those who've completed a course of treatment have waited those times when they have reached those targets when they entered, if that makes sense. So what next? We're always striving to improve the service. We're always striving to develop and offer more people within the borough the service. So our targets for this year going forward are to increase our access specifically to the over 65s. Our data shows we are not reaching out to as many people in that cohort as we should be doing. So that's one of our targets sort of going forward. And also to increase our access with our BAME population as well. We want to increase our group offer. We offer a number of different group therapies. We offer a long-term health condition group. We have a perinatal group that's just about to start. We have a worry group. We have a depression group. And quite an exciting development is we've partnered up with Mind to have a joint offer over our groups as well. So that's an exciting offer that's happening this year. So one of the reasons we want to increase our group offer is because actually we can see more people, and the group offers are, as they're the same sort of evidence-based treatment, the recovery is the same. People really benefit from a group because they form relationships within that group. And some of the groups as well, some people might have reservations about joining a therapy group, that they might have to speak, but not all groups are like that. Some are psychoeducational where you're just listening, so there's no expectation that you have to participate. Also, we have a specialist perinatal clinician that works in our service, and she's part of the early attachment service that Pennine Care provide, but she sits within our service as well. So she works with parents where there might be some psychological issues around bonding with the child. So she sees mums and dads and families around that. And she's also working with our some of our psychological wellbeing practitioners around our postnatal depression group as well that we're offering. So one of the ways we want to increase access to the over 65 is to run an overcoming depression group. So that's something that we're developing at the moment. I touched before on the long-term health conditions. We've got a number of our psychological wellbeing practitioners who have done a university training around working with people with long-term health conditions and the psychological issues that they might experience. And we're working on protocols and pathways in physical health settings. We've got a number of our PWPs based in sort of at the infirmary site in different health settings to set up those pathways. We're also working towards having a presence within the neighbourhood teams. So that's something that we're moving forward to do, so that referrals and pathways are easier to access. So we'll have a member of the team dedicated to each one of those teams. And the online taster workshops that I touched on, we've just launched our stress taster one, so anybody can access that stress taster course. There's just a link that's available. You don't have to be in our service to access it. We launched it a couple of weeks ago, and we plan to do a menu of those. So there'll be a worry one, there'll be a sleep one, and also we'll be delivering them in different languages. We're currently working on the Urdu version of it, but there'll be other languages as well. So we also are, we've got a good presence now on social media. You can follow us on Facebook and Twitter. We have an engagement worker that works with us, and he promotes all that. So, you know, please feel free to follow us on social media, and you can see there where all our events are happening and what our new therapy offers are. So that's our service in a nutshell, really. Thank you.
Okay, over to you now, if we can, please, over at Mind. Alice, I believe, is sharing next.
Hiya, can you all see the PowerPoint?
We can, yeah.
Yes.
So my name's Alice and I'm a Wellbeing Manager at Rochdale Mind. I'm just going to have a look briefly at the different support that we offer at Mind. We have a range of different support available, various different support groups. So we have the women's group, men's group, more specialised groups, as you can see on the screen. We have some self-help courses based on CBT. We have lots of one-to-one wellbeing support from our wellbeing coordinators. And then we've got the counselling service, which is for 12 plus. All of these are for local residents with mild to moderate anxiety and depression, low mood, stress. So we've got a variety of different projects with specialised support for BAME women. We've got the wellbeing group, refugees and asylum seekers, the Forward project, which is for people who have been involved in the criminal justice system or who are at risk of being involved in the criminal justice system. We have dementia and carers work, survivors of childhood sexual abuse. We've also got some practical projects. We've got the Complete Cafe, which is really good for self-esteem, confidence when people have been out of work for a while, getting them back into employment. We have our allotment, which we call the Growth Project. And we've got the information line and the Wellbeing Directory. Looking at new developments, we've got some exciting new developments due to start. We have the MASH worker. We've recruited a lady called Yusu who's going to be starting as a link worker. So she'll be linking in with the multi-agency safeguarding team, taking on people with mental health issues and getting them into the right services. So where they need the higher level support, she'll be doing the referrals, going with clients to the assessment, and linking in with Mind support where that's appropriate. Also working alongside with housing, drug and alcohol debt and other services that are needed. The other thing we've got starting soon in July is our listening lounge. This is going to be 2 evenings and 1 weekend. It's going to be bridging the gap between A&E and people being admitted onto the mental health ward. So this is crisis support. So it will be a safe place for people to go along and talk to trained member of staff when they are feeling suicidal. Safe environment for them to be in. I'm just going to pop you over to Frank, our advocacy manager.
Wow, where's all them slides gone? Yeah, next slide, Alice.
Next one.
Yeah, the advocacy one, I guess. Just get through them all now, the rest. Have you got them? Oh, yeah. Yeah, so I'm the advocacy services manager. We've had the contract now for NHS England, and we provide statutory advocacy across 3 units. Basically, it's a rights-based service where we support people detained under the Act, and so I will attend their meetings and help them get their points across, and basically try and get them away from hospital and back into the community in as smooth and timely a way as possible. Really, we've been back in the units since October. We did provide the service during COVID via Zoom and Teams and that, but it was nowhere near as what it should have been. It didn't really work. We are looking, if we ever go into a further lockdown, to develop a bit of an app for the patients who are detained, so we can perhaps improve the service. But fortunately, we're now back in. Over the last 10 years, we've supported over 5,000 people. We had lots of other contracts, but this is the one we've got now, and I guess we hope to keep this one because of the quality of the service that we provide, really. Next slide, Alice. Next slide, Alice.
It's on now. Have you not got the information line slide?
No, I haven't, no. But no, not to worry if it's on. This is just a useful number. It's an accessible service. It's always answered, even when the dedicated workers are not answered. It gets directed to other people's lines. So I think I've had about 5 calls today because quite a few people were in training. So I have to stress, it's not a crisis service, although a lot of people do still ring up in crisis, and we do sort of signpost them and refer them and what have you. So that's it's on now. Next slide, please. I finish that on.
Shall I talk about the training?
Yeah, go
So
on.
we've
Yeah.
got a variety of training at Rochdale Mind. The Living Life to the Full is a really good course for people who haven't done CBT before. So it's a basic introduction to cognitive behavioural therapy, and it's looking at identifying and combating negative thinking styles and behaviour patterns. They also look at self-esteem and confidence. And then we've got the Managing Anxiety course and the Managing Depression course, which obviously are more focused on those 2 areas. That's a good follow-on from Living Life to the Full. Managing Anxiety really goes into detail about negative thinking styles. And then the Managing Depression course looks at the cause of mood changes and ways of dealing with these. So they are really good self-help courses where people take a lot of information away. We get some good feedback about our courses.
And I think the good point is we are able to run them in the building now. We've gone to a lot of trouble to make the building COVID secure. We do have to limit the numbers to 15, but the staff are all doing lateral flow tests. They're all virtually all doubly injected now. So we're happily back in the building now. Admittedly, it can get a bit cold with all the windows open, but we're back in there. Fundraising. Obviously, we still we rely on donations. We do get some money from commissioners for some services, but we heavily rely on donations. And I think the point really, when a lot of people raise money for Mind, unless they specifically raise it for Rochdale Mind, it goes to National Mind. So tactfully, I'd like to make the point, if you want to raise money for Rochdale Mind, you have to specify it's for Rochdale Mind, otherwise it will go to National Mind, who don't need it as much as we do, really. but lots of opportunities to do that. These are just some of the quotes from people that we thought were quite positive that have attended various groups. I won't read any of them out because they're all there, but on the slides. But it just shows you the value and of the work. We do have to sort of keep all this sort of stuff for commissioners, but I think it's useful for everybody to see anyway. And I think that's the final slide, isn't it? That's just the information line and how to make a referral. All online. You can do the referrals as in the previous presentation. You can self-refer or be referred by GPs, etc. Anything else, Alice?
That's all from us. Thank you.
Super.
Brilliant. Thank you both very, very much. Okay, so thank you to all our guest speakers and all the information you've shared. We've not had any questions coming through the chat function during that conversation. So if we just go forward into the question and answers part now, I've got one question just come through from Sabrina, which we'll go to first. And if we literally do hands up or chat function after that, and we'll go through the questions if we can. Thank you. Okay, so the questions that we've got from Sabrina, we've got quite a few in there. So question one is there anything in your strategy to address unmet need around mental health, such as those with selective mutism?
Yeah, so is that for me?
I think that'd be suit. So I'm going to just read them out, and obviously between you decide who'd like to take which ones would be brilliant. Thank you.
Yeah,
just I can recording as well, sorry.
Yeah, so